lovely to see governors on the line, as well as many members of the public. Sarah will let me know at which point we think we're quorate with the arrival of staff governors. I'd just like to make a few comments before we get the agenda going, as ever comprehensive. The first is an enormous vote of thanks to the frontline teams at Swift, in particular our emergency department. Over the last week was our busiest ever week in terms of admissions into the emergency department, and on Tuesday this week we had 383 people attend the ED. We have never seen such numbers, and the resilience of our ED department is quite extraordinary. So I do want to thank them, but equally I do want to say to system partners and beyond our system more relevantly, that the fact that Swift is so good at offloading people from ambulances does not make it fair for ambulances to come from outside our system quite as regularly as they do, because our teams go not just the extra yard but the extra mile. I know ambulances across the whole of the Midlands is very stressed, but we do need to find sustainable ways of working with our ambulance colleagues. But my second point, which is related, is only please, members of the public, only come to the A&E if it is an accident and emergency. The primary care facilities we have in South Warwickshire are among the very best in the country, and we thank our GP and pharmacy and other primary care colleagues. Please go there first. If you've got an anxiety, dial 111. But we are still seeing almost a third of people attending the A&E not really presenting with an accident or an emergency situation. So members of the public, Swift is one of the very best performers, as we'll touch on today, in the whole of the NHS, but it will only continue to be so if we are able to work with system partners and members of the public to control the demand coming into the hospital at the moment. Finally, I'd like to thank all the executive directors, some of which are on the line, some of which aren't, because I know they bear the brunt of making the very difficult decisions at 2 o'clock in the morning and at other times, making very tough judgments on issues of effectively crisis. So I would like to thank all of those teams for doing that. And finally, I'd like to apologise for members of the public who and their families who are waiting longer for their care than ideally they would if we were less busy. So this is affecting real families day in, day out. And for ambulances that arrive with patients from outside of our county, they quite often stay much, much longer in our hospital than they need to and their families would like, because of the difficulties of getting people home when they're out of county. So all of these things come together. So I'd just like to, again, reiterate my thanks to all of our staff for the phenomenal work that they do, but do call out system partners to help address the underlying issues. So in terms of apologies for absence, Sarah, do you want to give me the latest apologies for absence, please?
Thank you. So we've had apologies from Governors Mike Flaxman, Caddy Harrison, Jane Knight, Julie Bell, Graham Nuttall and Sue Warner. And then non-executive directors are Sue Whelan-Tracy, Phil Gilbert, Yasmin Becker, and we've also had apologies from Adam Carson, the managing director.
Okay, thank you very much. Any new declarations of qualification for office or declarations of interest? Could you please raise a digital hand for me? Just for completeness on my own then, which is being updated for the Swift board, on my declarations of interest, it refers to the fact that my son works for Deloitte, who are our auditors. He is leaving Deloitte and is going to become head of strategy for GB UK, which is a medical devices supplier into the NHS. So just for transparency, I mentioned that. And the minutes of the meeting held on the 9th of November 2023. Were there any points of error that colleagues would like to emphasise in those? Please raise a digital hand. Okay, thank you. I'll duly sign those. And thank you, Sue, Bun and Verity, who are doing a phenomenal job. Verity, it's so great to have you on board. You're doing a phenomenal job for the Council of Governors. And in a similar vein, the minutes of the meeting held on the 15th of February. Were there any points of adjustment on these? Okay, nice and easy, thank you. So I think we go therefore to matters arising, and that is on page 39 of our pack. And there was for Adam to check the outcome of the compliance with the criteria-led discharges and feedback to governors. That is being monitored within the clinical teams, and readmission rates are being reviewed on a weekly basis. I don't think there were any other matters arising. If there were, would you care to point them out to me and raise a digital hand? Okay, thank you. So I've pretty much made my chairman's remarks in my introductory comments. So I'll move on to the assurance items, which is where governors request certain things that they would like to understand a bit better, and think will be helpful to members of the public to understand things that are going on. And we've got a few, and Glenn is kindly going to address each of those. The first is particularly with respect to what I said about the stresses and strains that we are suffering given the volume we're coping with, an update on staff wellbeing initiatives. Glenn, over to you, please.
Yeah, thank you, Russell, and good afternoon, everyone. Probably easiest way to assist in explaining this one is if I just can share my screen. Can you see my screen now?
Yes, we can, Glenn.
Lovely. So so what I'm showing you here is the staff intranet page that provides support for staff health and wellbeing. I won't use it for, ignore the slightly widened photograph of me that makes me look slightly tubbier than I actually am. What this page allows is for all of our staff across all of our services, hospital and community, to access support. So as you look at the right-hand side of that, for example, I'm feeling good, but I'd like support to keep myself well. If staff click onto that, beneath the surface of that, there's some mental health and wellbeing apps. There's some ways of staff having coffee together and connecting. There's some relaxation sessions. Under the I'm struggling and would like some support, there's access to our staff support services, our employee assistance program, chaplaincy, freedom to speak up, wellbeing ambassadors, bereavement support, counselling, talking therapies. So I won't go through the full list of those, but as you can see, they range across areas where staff might be needing financial support and advice, where they might be needing help with gambling or addiction, and where they might want some advice on having leading a healthy lifestyle. And in that one, there's nutrition, there's talk about taking lunch breaks and physical activity and how they can access different groups. So hopefully that gives you a little bit of a flavour of the range of things that we're doing to support staff. Obviously, we put a lot of extra services in during COVID, some of which was funded nationally, some of which came from the Captain Tom Moore money. But we've been able to maintain these services, and you probably noticed on that intranet page that that's a combined resource that we share across Swift and George Eliot Trust. And it's working and it's helping. And I think probably the best example you'll have heard me talk about before about how this is helping is when you look at our staff survey results and the specific questions in there about the support they get from the organisation and their line managers. which we get very good scores on. If any governors would like to delve into any more of that in any more detail, I could share a bit more on that, Russell, but hopefully that's an overview of the kind of things that we're doing to support people.
No, that's great, Glenn. And we're also aware in terms of well-being, and it was raised in an earlier session with Emma, about the importance of some of what we might describe as the hygiene factors like car parking. You know, there's nothing more frustrating than finding it difficult to find somewhere to park and then being stressed through that. So as Glenn has indicated, there's a whole panoply of different things that we work on. Any questions or perspectives on that? And we have got a full agenda, so I do want to keep us moving forward, but anything more colleagues would like to understand? Okay, I can't see a digital hand going up, so I'll move us on then to the second, which is an update on the Care Collaborative work. And it might just be worthwhile, Glenn, contextualising what the Care Collaborative is for members of the public who may not be aware, please.
Yeah, I thought it would be probably best to explain this. We've got a nasty habit in the NHS at times of overcomplicating things. So apologies for what I'm about to explain to you, but what we are doing across Coventry and Warwickshire is taking the opportunity that the Health and Care Act provides to delegate the authority for certain services down from the integrated care system down to lead trusts. And South Warwickshire Foundation Trust has been identified as the lead trust for Warwickshire for these care collaborative services, which are fundamentally our community services at the moment, with one or two add-ons. So what that will mean is, rather than a commissioner-provider relationship, we actually take on that delegated authority and act on behalf of the integrated care system to coordinate those services to deliver the best care to patients. So we'll take a delegated budget alongside that, and we'll be more outcomes focused in terms of the things that we'll deliver. But putting South Warwickshire FT in that role for whole of Warwickshire means that we'll also have to work around the services at Rugby St Cross that link into University Hospitals Coventry and Warwickshire, and the services in Warwickshire North that work around George Eliot. So that lead provider responsibility will also mean that we'll be working more closely with UHW and George Eliot around the services that link into their local acute pathways. At the moment, we are handling this through a subcommittee of the Integrated Care Board. So those responsibilities have not been fully delegated yet. And there's a lot of governance and meetings and arrangements in place to take ourselves through that first phase. But ultimately moving to that second phase is where we want to aim to be in about a year's time, where we're taking full delegated responsibility. And then ideally in the future, you start to add more and more services into that. So we in effect change from being a provider of certain services to acting as a commissioner for the population that we serve to integrate those services together. Our approach to this will not be for us to deliver everything as a trust. We're very good at the things that we choose to deliver, but there's also other providers of services that are better in their particular fields than we are. For example, the hospices. So we will be liaising with the hospices to ensure that we grow and maximise their capacity. We'll be working with primary care colleagues. We'll be working with the voluntary sector. And so this very much is in the spirit of our strategy as a trust to be the integrator, but not necessarily providing everything. This will also help us to focus more in the long run on preventative actions to reduce demand in the service, and we look forward to having a more direct role in some of those things in the future. Now, there's a session been arranged for governors this month to talk a little bit more about this. Zoe Mayhew will be leading on that, who's a joint appointment between ourselves and local authority and the ICS. So I won't go into all the ins and outs of it because she knows it better than I. But I'd certainly encourage those governors with more of an interest in this to engage in that session Hopefully that's helped to explain it, Russell, but I suppose what I'm saying here is we're in the early stages of a less delegated situation, because we, after all, have been providing those community services as a trust since 2011. But in the future, we'll be more the commissioner, and they'll be expanding and they'll be delegated to us. Hope that's clearer.
No, thank you, Glenn. It's an important journey we're on, because the healthcare system and social care system in the UK is too disjointed, and what Glenn is describing is the way of us bringing all of this together. I think it is fair to say, Glenn, that this journey is taking us longer to get to where we want to really make stuff happen than we originally envisaged. It is very governance heavy, which is a different way of saying sometimes it's been like walking through treacle, but it's well worth persevering, and I'm sure that at the end of the day will be to the betterment of the citizens that we look after. Any questions or perspectives on that? As Glenn indicated, there is a big training session coming up for governors in a couple of weeks. Okay, thank you, Glenn. You're earning your salary today, because you're also on again in terms of the operational assurance, the quarterly status update for the final quarter of our year. Glenn, over to you.
Yeah, thank you, Russell. So it's that point in the year where we are reflecting back on the full year. And actually what I'm talking through today will, a slightly shorter version of this will appear in our annual report for the year just ended. It's been another successful year, which we're all very proud of, and I thank you for all of your support as governors to take us there, because your contribution has helped along the way also. Kim will probably talk later about we managed to deliver on our financial challenge. We did really well against the A&E performance standard in that final month of March. Not had formal confirmation of this yet, but we are expecting to get £2 million for being in the top 10 nationally, and £2 million for being in the most improved nationally. Those are capital allocations, so that'd be really helpful with where we are from a capital perspective. And then we've seen further improvements in cancer and elective waiting times, and a great staff survey. So a really good rounded, and actually the staff survey, if you look at the staff survey, that tells you everything, because that kind of delivers on all of those other points. So what this report talks through is the objectives that we set at the start of the year. And I always say this, we try and stretch ourselves on some. So I don't always expect everything to be green on that red, amber, green rating, but there's a lot of greens in there, a lot of progress, a lot of detail, which I won't read out to you all. There's one or two areas that are amber, couple just to identify. One is some of the work we're doing on prevention, which links to the Care Collaborative work. We feel there's more scope to make further progress on, so we're giving that a bit of an amber rating. And that's being refreshed for the Care Collaborative. Also, the green plan, we did try and get ourselves into better measurement of our progress against carbon reduction. We've not quite finished that during the course of the year, but we will be doing that this year. And then there's one area that's rated red, which is the electronic patient record. Governors will be aware that during last year, we were in the queue behind our colleagues at UHCW. They delayed their implementation, so that meant that we weren't in a position to sign our contract with the service provider Cerner. UHCW are literally in the next few weeks going to go through their second planned implementation date. Looks like that's on track. So it looks like we'll be signing our contract with Cerner in the next few weeks also. So that will then ensure that our new electronic patient record is implemented next summer, so summer 25. So otherwise, really pleased with the progress that we've made in a number of areas, and indeed we met with governors a few weeks ago to talk about the objectives for the year that's now started, and another stretch set of objectives there. I'll probably just say one more thing, Russell, about the thing that you touched on at the start of the meeting, and how busy we've been from an urgent care perspective. And I think the response from all of the parts of the trust, this isn't just an acute response, it's our community services actually that have helped to innovate. and avoid admission and speed up discharge has been really, really strong. So despite often record, so I've never had so many days where we've had record attendance days. That 383 on Tuesday was a very high number. And earlier today, I was walking in the hospital corridor, and a member of staff tapped me on the shoulder and said she brought her son in on Tuesday into our A&E. And despite all of that demand and an overwhelmed department, he had really good care. She was really supported. The staff were calm and compassionate, and she was just really impressed with the team. And I think that sums up what they're about, that despite all of that, they keep going and deliver great care. So I'm happy to take any questions.
Thank you very much, Glenn. So good end to the year. As Glenn has indicated, Kim will touch on the finances a bit later, but any questions or perspectives on that quarterly status update from Glenn? Okay, thank you, Glenn. So we'll move on then to the patient experience assurance report. Fiona, over to you.
Yeah, hi. Thank you, Chairman. So this is our quarterly for the quarter four of this end of year position for patient experience, and Glenn's touched on it. Actually, it's a good report despite our pressure and the activity. So it's our standard report that we see through the board of directors and our and our clinical governance committee every quarter. It goes through the complaints, the PALS, the friends and family test, the bereavement services, translation services, but it's a positive picture generally. The vast majority of our patients do report a good experience, both verbally and through those more formal mechanisms. And we sometimes don't get it right, sorry, and we do sometimes have complaints put in either by email or letter, and we respond to those professionally and appropriately. But you'll see some of the themes that have come from that. When we triangulate them, there isn't one theme that stands out. Last year, we did set some quality priorities around communication specifically, because that was something that was stronger as a theme, and that communication problem that we were seeing has reduced. And so the mechanisms that we put in terms of our quality improvement have proved successful there. But there's always going to be a category that's at the top, and at the moment it's clinical care, and we're taking action and learning from that feedback, and we welcome that feedback because it helps us to focus on that improvement. Just want to shout out near the end of the report is a section about our volunteers. Our volunteers are hugely important to patient experience. We've got over 500, 600, I think, actual volunteers that support us across the community and the hospital, and they really add that extra added extra part to patient experience. This coming year, we're going to be focusing on growing that volunteer army, and particularly reaching out to charitable organisations, third sector organisations in our communities, which can also help our patients before they're in hospital, after they're in hospital, managing their long-term disease, really preventing them hitting our services in the first place. And we need to do a piece of work to make the public more aware of that added a layer of health advice that they could seek. And the other thing that we're going to be concentrating on this coming year is really doing more about analysing or hearing the voice of our public. We hear a lot of feedback, as this report presents, from our patients through complaints and compliments and friends and family tests, and our staff give us that as well. But we haven't been as good at reaching out to our public using, our local authority colleagues, using our Health Watch colleagues. They've got the networks and they've got the intelligence that sometimes we're a little bit siloed in health. And so I value the public's view on as we step into that project, and views and support in getting a much wider view of from the public of our services and what we need to improve. I'm happy to take any questions.
That's great, Fiona. Just before I invite questions, just in terms of the volunteers, our volunteers are a wonderful asset for Swift. To put it in some context, we have if you do a size for size adjustment, we have 4 times the amount of volunteers at Swift than is at Worcestershire Acute. That puts it in some context about how many volunteers we have. But as Fiona says, you know, there's still an awful lot of volunteering organisations we can work with, and volunteering is wonderful. It gives all of us a purpose in life when you put others first. Any questions or perspectives to Fiona? Jean Arrowsmith?
Just say that post-COVID, because that put a delay on everything, we're now in the stage of organising engagement evenings, afternoons, mornings with the public on issues that are relevant to them in their area, but also relevant in terms of prevention and their health. So just to let you know that we have been meeting all on our little own with coffee and stuff, and we are organising it. Thank you.
Thanks, Jean. Thank you. Really great.
And any other questions or perspectives to Fiona? So Kim, 1 year's finished, a new year's started. How did the year end? Over to you for the finance assurance report, please.
Thank you, Chair. So we are required to deliver a break-even plan, and that's a statutory duty that all NHS organisations are supposed to deliver against. And we obviously pride ourselves in terms of making sure that we do the best that we possibly can in order to deliver that. I'm pleased to report that we did deliver a £17,000 surplus. So we did achieve our statutory duty, which I think is really important, really, for us to recognise. And that's in the backdrop of the increasing demand and the challenges that we've just spoken about, but also in the backdrop of the industrial action as well, which clearly did impact on our ability to deliver, safe services, but also in terms of recovering from the industrial action as well. So those have been really a challenging situation, really, that we've had to deliver. We also had to deliver a large cost improvement programme, but again, with the operational challenges that we had, you do need headroom, so that was a challenge for us. However, we did manage to deliver with use of some of our balance sheet flexibility, as well as achieving doing better in terms of income in other areas, but also, recognition of our Excel in Everything programme, which was really successful in terms of delivering some of our service improvement work. And that's obviously something that we're pushing for and continuing to do moving into the next financial year. In terms of capital, we did deliver the capital programme, which was a £45 million capital programme, and we have managed to successfully carry forward some of our capital expenditure allowance, shall we say, by purchasing shares in our Innovate, our joint venture company, Innovate, which we did raise to the Council of Governors, I think, at the last meeting, but that amount that we did invest was 15 million, so that's within the delegated amounts that was approved by the Council of Governors. In terms of next year, just wanted to highlight really that it's been really challenging. It is still a challenging position financially for the whole of the NHS. There are some very, very difficult conversations being held nationally. With all systems around the financial deficit. It's very clear that the more recent plan that's been submitted, that's been aggregated, that was submitted in beginning of May, is not affordable. So those national conversations are being held with all the various systems. The Coventry and Warwickshire system has submitted a £44 million deficit plan. Within that, Swift have actually managed to submit a break-even plan. Now that is not without any risk, and clearly that our job is to manage those risks moving forward in terms of next year. But with our Excel in everything, and we will obviously try and make sure that we maintain safety as well as deliver performance and deliver the money. But that's not without some challenges for us. Key thing as well is that we've made really good progress as well, I think, in terms of our agency reduction programme, and that we will continue to drive that into the next financial year. But we've also managed to maintain safety, which I think is really important as well for us to recognise, and I know Fiona touched on that. Predictivity and service line reporting is key for next year. The predictivity word is very clear, a key measure for next year around ensuring that we understand the increase in our headcount that the NHS has seen overall, but that we are actually recovering and delivering on the predictivity that is also expected with the funding that has been given to us. The other thing to mention was the capital incentives. Just had a call actually with the national CFO, and he's keen to actually continue with the UEC capital incentive programme. So expecting to hear some announcements in the next week or so about the new scheme. So hopefully that will also mean that we will hear officially about the money that we will receive on the back of our performance on the year just finished. Happy to take questions. Thank you, Chair.
That's great, Kim. And Kim uses a phrase, it's a statutory responsibility to break even. It's worthwhile remembering, and Swift is the only trust in the whole of the Midlands which has a combination of, on the standard operating framework, a level 1 rating, a CQC rating of outstanding, and year in, year out delivering break even. So it might be a statutory responsibility, but very few do it. Questions and perspectives to Kim, Michael?
I was just going to say that we seem to be one of the only people who manage to break even every year, be it a statutory duty or not. And I think Kim and her team are to be congratulated together with everybody else, because it obviously can be done within the money. It's just how you do it.
Well, I think the thing, Michael, which is absolutely key is our productivity and our what are called reference costs. We are a very productive organisation, but your point is well made. If we can do it, others can do it as well. But not everyone has our leadership team, which is why we're blessed with the executive directors we've got. Generally in life, I found performance of an organisation depends on one of two things: the quality of its people and or the quality of its processes. At Swift, we are blessed to have good people and good processes. Any other questions to Kim? Kim, make sure we break even again this year, please. Kim is the one. It's always a bit unfair to say, Kim, please make sure we break even, because you're the one who adds it all up for us. But you take the principle, as a team, we need to make sure we break even again. So we'll move on then to a couple of assurance reports from non-executive led ones. The clinical governance assurance report. David Sprague, Dr. David Sprague.
Yeah, these are actually board reports for 4 months. From December, January, February and March, and I take them as read. Generally with these reports, I encourage people to just check on the items of concern that I particularly want the board to be aware of. Some of the ones that were actually concerns back in December now are well on their way to being addressed, and in particular things like the haematology issues are improving enormously because of the work that's being done by the teams, and it's being rapidly followed by our cardiology colleagues. So I'm happy to take any questions.
That's great, David. Any questions to David? David, you've been around a bit. Take that in the right way it's intended.
Yes, thank you for that.
What's worrying you most as chair of clinical governance?
I think it's actually the amount of activity that our teams are having to deal with what is actually a relatively flat resource. And that, when I'm talking about resource, I'm not talking necessarily about money, it's people. And I mean, the examples for the ED this week are a great example, aren't they? That despite the fact there's been considerably more than we've ever had before, they still managed to cope extremely well. I actually went into ED this morning and they were remarkably calm considering the hassle that they've had over the past few days. So I think it is quite clear that a lot of this is the teamwork is helping. But the increasing population in South Warwickshire, particularly the increased diversity in demographic we're getting, it used to be we always were increasing our elderly significantly. Now with the new housing, of course, we're also going to increase our maternity as well. So as you note, I've flagged on more than one occasion concerns about maternity activity, and discussions are going to have to be had. We are safe at the moment, but I do have some concerns that there is at some time in the future we may pass that activity threshold where it starts to become unsafe. And again, work is being in place for that.
Very helpful. Thank you, David. Roger?
Yes, one question to David about cancer services. Are we managing to keep up with the tide? And I note the increase in referrals. Are these all appropriate referrals? Are we still seeing the same sort of volume of actual, yes, this does need to be checked, as opposed to incidental?
I understand what you say. Yeah, in the main, the answer to that last one is yes. The conversion rates, which I think is what is actually still demonstrating that the majority of these referrals are entirely appropriate. I would worry enormously if we had 100% conversion rate, because that would mean there'd be an enormous number that were being missed. But I think we are struggling still. There are some cancer services that are well on top of things. There are others that are struggling. A lot of the ones that struggle are the ones where we rely on others to provide us expertise, and the others in particular, the oncology teams, because of course we don't have oncologists amongst our team. We rely on colleagues at UHCW in the main for those. And of course they are struggling, so that makes some of the issues that we are struggling with even more of an issue. I don't know whether that's completely answered your question, but it is a concern, the cancer services.
Thank you. Ruth, then we'll move on. Ruth?
I was under the impression, David, that we were going to employ a couple of our own oncologists.
That's certainly been discussed.
David?
We aren't in a position to...
David, can I just suggest that's better answered by Glenn?
Oh, yes, sorry, yes.
That's okay. Glenn?
I'm sure David knew the answer.
I did actually know the answer, Glenn.
So, yes, Ruth, we continue to have conversations with colleagues at UHCW who provide this service, but we have gone out to recruit also to bridge that. And we're also having conversations with colleagues at Worcestershire Acute as well, who have oncology, who are directly employ oncologists also. So I can see one or two, and we're not stopping any one of those options. And so hopefully a combination of solutions will bring us more capacity before too long.
Thank you.
Okay, if there are no further questions for David, and I'd encourage members of the public to join us at our public boards, which occur every month, because David gives an update there, and we also get updates in terms of quality and safety from Fiona and Charles Ashton. We'll move on then to the audit assurance report. Richard Colley, over to you, please.
Hi, Kim and the team and the execs have done a remarkable job this year. With the CPIP, a 14 million circa, next year they've got to get to 20, so there's got to be some magic done to get to 20 million, and life is getting very difficult doing it, so there's an uphill challenge for them, so we need to be supporting with these structures going through. I think the other couple of things just to mention to you are there continues to be, I think, post-COVID, a problem with violence and abuse of staff. There was a 23% increase to something like 422 in the last 6 months, 154 physical, 268 verbal abuse. So our staff are being threatened, and also it's probably the mirror image of problems with children and other patients' mental health. There's a lot of mental health problems out there, you know, so going through the process. I think the other thing we spent a lot of time in the last quarter has been looking at cybersecurity and checking that we're there. We had a foundation group board like 2-3 months ago, and we were challenged by an external advisor, just can you answer these questions, which we've responded to. So I'll take any questions.
Thank you, Richard. Any questions to Richard? Roger.
Yes, Richard. At an earlier stage, audit committee were following up on contract management and procurement and seeing whether the efficiencies could be brought into that system. Are you able to give any assurances as to how that work is progressing?
That work is ongoing. There's a new system coming in with bronze, silver and gold contracts, and we're going through that process, going through the contracts onto a new computer system. That is ongoing, and once we get those top 10 contracts or 20 contracts, I think it'll dial down. I'm not 100% sure that we've got the definition by bronze, silver and gold right, because I think we probably need another variant into it as to what is critical. Like if we had a payroll contractor went bust, you know, even though it's only 160,000 a year, you know, we would be very difficult place. So I think that's the only bit of it. But until I see a list, I can't challenge that.
And Roger, there is moves afoot across the whole of the ICS to address the procurement opportunities of the economies of scale. I'm working on certain procurement contracts across the system. Having said that, we've been doing that for quite a while across the foundation group, and the added scale of Worcestershire Acute joining us is throwing up further opportunities in terms of procurement. Okay, thank you, Richard. Thank you for your hard work. We'll move on then to the variety of different projects which our governors are involved in. And I can't emphasise enough to members of the public how much governors get involved in project work across the whole of the organisation. So thanks to governors for their work. The first up is a Community Diagnostic Centre project update, which, given that Mike Flaxman is absent and is the governor rep on that, I will take as read. Any questions on that update, which is on page 100 of our pack? Now, given how busy Mike is, Roger Lloyd has kindly offered to be the Deputy Governor Rep for that CDC project board. Thank you, Roger, for volunteering for that. If any of the governors have a problem with that, could they please raise a digital hand for me? Okay, so super. That gives us just a level of cover on that, so to speak. The second sort of update then is the Elective Hub project board. Again, I will take this as read. An enormous amount, as anyone who's visited the hospital will appreciate, of building work is going on at the moment, where the starting point is the development of this elective hub. So thanks to our estates team for the work they're doing. Kim did touch on the fact we have spent close to 40 million of capital this year, but you can see it in terms of boots and spades in the ground, so to speak. Any questions on the elective hub update, which is on page 102? Roger?
I think from information that we've heard elsewhere that certain time-lapse photographs are being taken to show the work being done. I'm wondering whether it's feasible for this to be uploaded to the Trust website so that people can see what's actually going on.
Great idea, Roger. Glenn's going to tell us what we're doing with them. Glenn?
Yeah, I think we may have put it on our on one of our social media platforms, but I'll check to see whether it's going on the website. I also bumped into Jean Arrowsmith as we were knocking it down the other week, so it is quite a dramatic change to the site. So I'll see if we can get it onto the main website.
Yeah, and again, I would like to apologise to members of the public for the inconvenience of all of this building work, but it is very much to the medium and long-term benefit of the citizens of Warwickshire that we're doing it. So short-term pain, long-term gain, so to speak. Okay, well, thank you, Mark, for your involvement in that project group. The next up then is the Ellen Badger Hospital Site Redevelopment Group. Mike, you've been there since the start. Thank you for your report. Mike, anything you'd like to put out? Mike Wells?
Thanks, Russell. Just a couple of points. The latest project, I'll take the report as read. The latest project board was yesterday, and it's really interesting to see that we're now starting to talk about very detailed things like how and where the historical artefacts that came out of the original building will be displayed, and those artifacts are currently on loan to Shipston Museum. So if anybody's interested in going and seeing a display of artifacts from the history of the old hospital, then it's open from 12 till 4 every Saturday and Sunday. But other than that, happy to take questions.
No, thank you, Mike. Any questions or perspectives to Mike? I would just like to say to citizens of Shipston, this is a wonderful development which we are spending a lot of money and putting a lot of effort in to the betterment of your community. It's your hospital. Clearly, it may not be entirely what some citizens would like it to be, but it is going to be a wonderful facility which will help provide the level of health and well-being for the citizens of Shipston going forward. So we are delighted to be building it on your behalf. Thank you, Mike, for that. We'll then move on to the End of Life Committee, which always sounds like a cheery subject. Michael, over to you.
Thank you very much. This is a professional committee. I'm an observer, and my observations are printed, and I ask everybody to read that. I would just like to say, as I have several times, I'm very impressed with the efforts that are made continuously to improve our end-of-life arrangements. They're terribly, terribly important because not only do they affect the person who's concerned, but obviously a whole of the family and people related to them. And it is very, very important, and it is taken that way by the professional colleagues who I observe from time to time. And they are endeavouring to embed this in every part of the hospital to cover that dreadful time when people do die. And I'm very impressed by them.
Thank you, Michael. And as you've often heard me say, in my opinion, the two most important things we do as a trust is to bring life safely into the world and help life leave the world, this world, with dignity. So it's lovely of you to say that. And there are phenomenal efforts which go on with our chaplaincy services, with our palliative team. You know, we're very blessed to have palliative consultants within Swift, which many organisations don't. So I think your points resonate well, Michael. Thank you. Any questions or perspectives to Michael? And Mary. Mary, if you yeah.
Are we assured now that the supply of palliative care medications in the community has resolved? Because that was an issue for a long time, but it's gone quiet. So I'm hoping that means it's improved.
Fiona?
Yeah, there's still work, there's still improvement work being done, but it is being led. We are engaging in it, but it's led by our ICB colleagues. Mary, I think I am assured that it is an improving position, but we're not sitting back on our laurels.
Thank you.
Yeah, I think the thing I would add, Mary, is I'm absolutely sure on occasion at 2 a.m. in the morning, when there's a need for appropriate drugs to be available, that some families really struggle. We do a lot to try and ensure that, despite it being potentially a long distance to travel, the drugs are available. But it's still, in my opinion, whilst we're doing good work, it's not 100% perfect, and so it is a continued area of focus. Any other questions or perspectives? I would like nothing more, Mary, than us to be able to ensure that no one dies in old age in pain. And we should be able to achieve that as a system, and certainly it's one of my ambitions for the system. We'll move on then to the Falls Prevention Steering Group, and thank you, Pat, for your work on, David, your work on this. David, anything to be reported on this? It's got nothing to report, but anything to report?
No, I only received the papers yesterday, but I had a quick look. Basically, falls levels are continuing at a more or less average level. And in my last report, I did notice that certain wards hadn't completed their falls training, and were very short, but that has considerably improved now. So we are getting there for full training.
Okay, thank you. Fiona, anything you'd like to add on that?
Yeah, I think the wards that have the most vulnerable patients, we do try and prioritise for their falls training, and we are trying to adapt our training to go to the ward rather than then come away, because with the demands on our service at the moment, it's really difficult to release. You know, you've heard many times about today about how we're balancing things. So this is one of the balancing acts that we're holding at the moment. So, but yeah, we're trying to adapt our training to make it easier for staff to do whilst they're still working.
Okay, thank you, Fiona. And Sharon, your hand went up. Sharon, you're on mute. Still can't hear you, Sharon. Okay, Sharon, if you can maybe pop your point in the chat box, I'll make sure it's handled. John, if you could stop moving your camera because it's wobbling around a lot, and we'll move on. Thank you. The Medication Safety and Optimisation Committee. Mary, over to you.
Thank you, Chair. Apologies for not having apologies for not having any written reports. The timing of the meetings was such that it wasn't possible for me to get the report in time for the papers. And some of the issues that are discussed at the meeting have already been put into the Patient Care Committee minutes, which come up later. There was no meeting in February, so there were two sets of data to be taken in March, but the March meeting then was not quorate. There was no chair and a lot of key members were missing. This again is indicative of the pressures on staffing, I think, particularly the clinical staff. So the deputy head of pharmacy led the meeting and presented every item, just going through the motions, as she put it, just to keep things moving. And because of the problems with this group, the head of pharmacy or the deputy head of pharmacy are meeting with Fiona and Charles Ashton to discuss the committee membership and how to make that more effective. I don't know if that's happened yet or not, Fiona, but that's on the agenda anyway. As usual, they discuss the medication incidents and there's, sorry?
You carry on, Mary.
As always, they discuss the medication incidents. There was a significant number around antibiotics and insulin. That continues to be an issue in the community. The main area in the process that is an issue is the administration itself. The incidents with harm were discussed in a lot more detail. Medical devices are now covered by this committee, and because pharmacy now has access to the medical devices incident data, these were discussed. There were 41 incidents in February and 38 in March. From April onwards, these are being categorised into separate groups of equipment failure and staff errors, so it could be possible to pick out the implications of the work. There were only 2 incidents relating to the electronic prescribing and medicines administration, or the EPMA, in February and 1 in March. This is a much improved situation because of the implementation of EPMA at the front door. Safety alerts are discussed, 3 this time. The fluoroquinolone is no longer first-line antibiotics. Codeine Link has been withdrawn from over-the-counter purchase, and valproate in pregnancy. The valproate in pregnancy particularly was discussed because of there are a lot of safety implications, and there would need to be new guidelines, a lot of liaison with our primary care colleagues, patient information, and possibly even additional clinics, which there'll be a group of people looking at the implications of that. There was a report on the controlled drug audit carried out by the pharmacy technicians. Areas of concern were identified and action plans have been put in place. A pharmacy technician now visits each ward once a month to assist in controlled drug housekeeping. This is a stretch for pharmacy staff at the moment, but they hope that as time goes by, the housekeeping will improve, so their visits will be shorter. And the final issue that was discussed for some time was digital data security relating to medical devices. This could involve a significant amount of work going forward, presumably for Innovate as part of our governance issues. That's all I'm saying. If I've got any questions.
Thank you, Mary. Very comprehensive. Fiona, is there anything you wanted to add on the early points that Mary was making?
Yes, Charles and I did have met with the medication safety officer, Anne Hutton. We're working through, it's similar to the Falls really, how we can engage clinical staff alongside doing their day job to engage in medication safety agenda rather than sitting, or if possible, as well as sitting in a committee to discussing it. And so we've linked to matron Jo Poole, who is really passionate about medication safety and sits in her portfolio to try and get key members of staff engaged in discussions and improvement projects actually in the ward areas.
I think that was one of the main issues. There's a lot of discussion happens, but that it actually wasn't going anywhere, that they needed people like matrons to get engaged with the outcomes of the meeting.
Is it going anywhere, Fiona?
I've engaged a matron. I don't know the outcome of that. It was only about 3 weeks ago, but I'm keeping a close eye, and I've set her objective as that.
Okay, if you can keep us brief, that would be great. Mary, thank you for your hard work on that subcommittee. We'll move on then to the patient experience group. Sharon Ellsworth, although she's with us, is having problems with a mic, so she will circulate the minutes, but I'll take her report as read. Any questions on the patient experience group update? Okay, Sharon will circulate the minutes. Thank you, Sharon. Hope your technical issues get sorted. So we then move on to the patient letters, personalisation and M-modal working group. Pat. Pat, if you're talking, I can't hear you. Okay, not sure what's happened with Pat. So I will take that report as read. Any questions on that short report from Pat? Mary?
Yes, Pat's saying that she stood down from this committee. I don't know why, because the governors are there to act as sort of in a patient capacity, if you like, and I would have thought that any information that's going out to patients, it's useful to have a governor there to have their input as to the appropriateness of it for the patient or whatever. It seemed rather unusual for a governor to stand down from a committee like that. I think she should continue. Okay,
we'll take it outside. Mike, anything you want to add to that?
Yeah, I've exchanged emails with Pat about this, and it came to a natural end, which is why they've moved on to a set of letters now that don't involve patients. They're doing something else. So it actually got to a natural break point for it to step out.
Okay, great. Thank you, Mike. Okay, we'll move on then to the patient portal engagement forum. Pat, back with you, if you can hear me. Not doing very well with the technology at the moment, team. I apologise for that. So I will take again Pat's report as read. Any questions on Pat's patient portal forum update? Okay, so we'll move on then to the Radiation Protection Committee, where I don't think anything to report.
No, the next meeting is on Monday, 13th of May, so I'll be reporting after that.
Thank you, Carolyn, that would be wonderful. So we'll move on then to the Safer Discharge Group. Jean, love to have you back with us, Jean.
Thank you. I just want to reassure everybody that we're really phenomenal in the way we're approaching discharge. We've had what we call a special week, a perfect week, where all staff, and in particular the pharmacy staff, have been out on the wards and they've been liaising with everybody. We've also had a rolling thing where we've had presentations so that people who are on different shifts can attend. That was well attended. The fire service presented all of their work. The frailty ward was looked at to provide additional support. The drop-in sessions, the road shows. I mean, it's just been amazing how hard they're working, and yet how much effort they've put into having another fresh look and making sure that Safer Discharge is as it should be. We actually should have had a meeting yesterday of the Safer Discharge Committee, but because of how many admissions and discharges and hard work that everybody is having to cope with, in fact, it was cancelled. So we're looking at that. We're actually also looking, they've just put out 2 new protocols, which are out for people to have a look at, and that's to do with TTOs and goes into a lot of detail. The other area that we're now focusing on is to do with our volunteers and Julie's work in terms of making sure that when drugs aren't ready at the time that people are leaving, then the volunteers will be on hand to take these medicines out. And it's absolutely amazing. I mean, they go as far as Chipping Camden, and it's 7 days a week, and the support is just fantastic. I even learnt recently that they do hundreds of miles, but they don't like to claim because they don't want to let the trust down. So that is sort of typical of the attitude of our volunteers and our workers. So I just want to say that we are working on a couple of issues at the moment, but we should really congratulate them, and people should know that we had, a massive increase, as you said at the beginning, in admissions and discharges, with many of those being from out of area. So I just say a big thank you.
Okay, great. Thank you, Jean. And as you say, we do have a wonderful group of volunteers. And again, just for members of the public, at its simplest, discharge is so important because unless we discharge people in a timely fashion, two things happen. If people are left in hospital too long, they get hospital-acquired functional decline. They start to get more ill again because they should be up and about and at home. The second thing that happens is our beds get blocked, and therefore we have problems in terms of the flow through the hospital. So effective discharge is absolutely key, and it is why across the foundation group there is such a focus on it. Questions and perspectives to Jean. Mary?
You're muted.
Mary?
Sorry, in Julie Bell's absence, just to clarify that they do work 7 days a week, but only 5 till 6:30 on weekdays and Saturdays and Sundays all day, I believe. But I just wanted to clarify that they, after 6:30, was the transport's supposed to go over to taxis. I think that's the message.
Yeah.
Yes, I've got an email from Julie, which I forwarded to the team, and we're actually, Fiona's attending the patient care committee next week, where, as I said, we'll go into it in a lot more detail and really focus on it and make sure that we're not only meeting the patient's needs, but also the volunteers and Julie.
Yeah, no, thank you, Jean. Keep us brief. Thank you for the question, Mary. We'll move on then to the Salix project board. John, you're looking after this for us. John, over to you. So, John?
Well, there's nothing much to report except a lot of activity going on, and it's all work in progress. So I would say nothing much apart from work in progress.
Okay, and I think it is, and Glenn, you'd confirm this with me, we are one of the leading organisations in terms of pushing for the sustainability agenda and making sure that for the people of Warwickshire they can be proud, and for our staff they can be proud of the organisation being very much at the leading front of ensuring we are from an energy perspective a sustainable organisation. Thank you, John. Please continue to keep us briefed. We've then got the serious incident review group, and there's nothing to report, I'm informed, on this. So we'll go then to the wayfinding strategy group update. Roger. Roger, if you're talking, I can't hear you.
Sorry, no, I had to take another call, and headphones and phone didn't work. Wayfinding, yes, it's going forward quite well. We've just been given, the wayfinding group has just been given a prototype map to try and experiment with, see if we can navigate round the hospital effectively. We think from the demonstration we've seen that yes, it is working, and it's certainly a very powerful tool. What we've got to do as a group is see whether we can spot the odd errors in it, or how it can potentially be improved. But as a project, it really is powerful, and if ultimately Swift adopts this as a policy, I think everyone from staff to patients to visitors will find it to be a great advantage. Other than that, the rest of it seems to be work in progress. So as per my written report.
Okay, thank you very much, Roger. We all know, I think, as visitors to the site, how complicated it is on occasion. So to find where you're supposed to go, and all of us who know the site will have helped people find even the most obvious of places on occasion. So the wayfinding work really is important, and it's great that we've got some solutions in development, which might be really powerful. Thank you, Roger. Please do keep us briefed. Any questions to Roger? Pat?
I'm just going to go back to say that I'm now connected with the world again, if anybody wants to hear the reports. Sorry about that.
That's okay, Pat. I think that's wonderful. Glad your technology is now working, but I think we've been able to cover off most things.
Right.
Any other questions to Roger? Sharon, you're quite right. We do have the wayfinding volunteers and they do an excellent job. So thank you for everyone involved in that. So we'll move on then to some governance matters. The first is the General Purposes Committee draft minutes on the 11th of April. Mike, anything you'd like to add to these or pull out? Mike, if you're speaking, we can't hear you.
No, sorry. Caught me on the hop there. No, I take them as read.
Okay, thank you very much, Mike. Any questions on the GPC draft minutes, colleagues? Okay, we'll move on then to the Patient Care Committee approved minutes in February, from March, and the draft minutes from April. Andy, anything you'd like to pull out of these?
I think just that minutes reflect the enthusiasm and engagement of the committee members and their commitment to patient care. And we've heard earlier on about the issues on POs, which Fiona's kindly coming to our next meeting about.
Okay, thank you, Andy. A bit difficult to hear you, just so you know, Andy. I don't think it was just me, but got the gist of what you're saying. No worries. Any questions or perspectives to Andy? Mary Malloy?
Yes, it was just in the set of minutes for the, which one? The 8th of April. They're still draft minutes, so this will be corrected at the Patient Care Committee. But I wanted to highlight that it says I had a concern regarding GP out of hours service. That wasn't specifically my concern was about the process of people coming from GP out of hours into A&E, into minor injuries unit before they could get an assessment X-ray. So I didn't want it to read that I was complaining or concerned in any way about the GP out of hours service, because that wasn't the case. I wanted to clarify that publicly.
Thank you, Mary, and let's make sure the final minutes have that adjustment in them. Any other questions to Andy? Thank you, Mary. If you could take your hand down for me, that would be great. Thank you. So we then move on to the Membership and Engagement Committee draft minutes, which are from Mike. Which I'll take as read, given Mike's absence. Any questions on that report, please? Raise a digital hand. Okay. I'll therefore move on, as I can't see any raised digital hands, to the draft quality report. Fiona, for last year, over to you.
Yeah, thank you. So if you've had a chance to read the quality report, I hope you've read. My intention was to collate a number of the KPIs that we monitor, the outcome measures that we monitor around quality, and the intention is to pull it all together. There will be things that we've missed, and some of it we've already talked about, but this is based on a sort of statutory format that it was previously a requirement. So I see it as a celebration of what we've achieved in the year. I'm happy to take comments or questions. It will form part of our annual accounts for the year, but the members of the public, governors, have this opportunity to read it and send me any comments or additions or suggestions for change that you want to make before it's formally published.
Thank you, Fiona. I mean, it is a great sort of summary of all the good things going on. Just for members of the public, we know we don't get everything right, and we apologise for that. But we get more right than many other trusts, which is, I think, the key point. And the teamwork and phenomenal efforts of the teams throughout the organisation are sort of evidenced in this report. and I know Jean has been recently a customer of ours, but Jean, any questions or perspectives to Fiona?
Just to say they were amazing. I just wondered at what point in the meeting that you want to do quality targets, you know, the annual quality targets. Does that come later or does that come in this bit?
So Glenn, step in if you want to. So we've already set the quality priorities. We did it as part of our conversation about setting objectives for the year, Jean. So we've set a set of, we've consulted with you, we've talked to our staff and governors and public about what our priorities are for the next year, and we've chosen a set of objectives for the year and we've shared those with you. What we're doing this year, because we're not mandated to have a separate set of quality priorities, what we've suggested is aligning, identifying some of those objectives as quality focused, because they are, because that's why we do what we do. But the discussion we had a couple of weeks ago with non-execs was really thinking through what the measures of quality would be under those objectives, rather than having a set that is separate. But happy to talk that through outside of here, Jean.
Jean, I think it was when you were off. We had it at the last Council of Governors away day, and that was a topic of conversation there. Glenn, anything you wanted to add?
Yeah, that's what I was going to say, Jean. So we discussed this at the round table. I think what we probably ought to do though is just formally bring it back here, just so everyone's familiar with what was discussed.
Yeah, no, super. Thank you,
Just
Glenn.
so Fiona knows, we're actually doing one in outpatients, so I'm not sure if you're aware of that. So I better make sure that you are, because we've just already started a lot of work about the way we did the A&E one last year. Well, we're doing one in outpatients this year.
Brilliant, Jean. Thank you. Thank you for all your support.
Thank you, Jean. Okay, team, we'll move on then to the Register of Governors and Governors' Interests. Welcome to Matthew Gain, who's taken over from Sophie Black as our stakeholder representative of the University of Warwick Medical School. So, Matthew, nice to see you. Sarah, anything you particularly wanted to put out?
Just that the registers of both registers have been updated as part of the annual review process. All governors were asked to update their declaration of interest forms, which the interests have been captured on the register. I'd just like to remind Councillor Liz Coles and Bernard Usselman to update their declaration forms, please, and submit so we can capture those on the register, and then both will be published on the website. So they're here for receiving and noting. Thank you.
Thank you, Sarah. Any questions on those? Liz and Bernard, if you could do that, that would be wonderful. Thank you. Okay, we'll move on then to the resignation and appointment of governors. Sarah, anything apart from Sophie and Matthew you wanted to touch on?
Also, just to note that we have received the resignation of Roger Weddell, who was the staff governor for clinical support. We will go through the general election process later on in the year because we need a new council in place for the 1st of March 25. So again, this report's for receiving and noting. Thank you.
Thank you. Any questions to Sarah on that? Just a couple of things from me. I really do appreciate staff governors who join the Council of Governors. I know you're under enormous pressure at work, and for you to be able to find the time to join us is greatly appreciated. So, Emma, Bernard, Kathy, and others, thank you very much. The second thing is just to say thank Sophie Black, who has been with us a number of years. She's been a great ambassador for the medical school, and I know, Matthew, you will be similarly impressive and contributive to the work that we do. But Sophie, thank you very much in absentia. We'll move on then to the reappointment of the Trust Chair. Roger?
First of all, yes, right. The position of Russell as trust chair is at the moment pivotal really to the foundation group and SWIFT as such. We are in a position where up to today we are with Russell having been appointed substantively to the other foundation group trusts until March 2026, but not at SWIFT. And this report is recommending to Council of Governors that we correct this and make it clear that Russell, as chair of the foundation group with the other trusts, can continue in that position at SWIFT. Ultimately, this will be, unfortunately, the last time that we can extend Russell's term, because NHS England have indicated that they're prepared to waive the rules this time round, but no further. They haven't as yet decided how to cope with the idea of a foundation group, how to appoint chairs of different trusts, i.e. NHS trusts and foundation trusts at the same time. They haven't got their heads around those rules yet, but hopefully in the next year they will do so, and the next Council of Governors can then decide how to take matters forward. But the recommendation from the Nomination and Remuneration Committee is that we extend Russell to the 26th, sorry, to March 26, in line with the other trusts of the foundation group.
Thank you, Roger. Any questions or perspectives to Roger? If you're not happy to approve, I won't hold it against you. Please raise a digital hand. Okay, duly approved. Thank you. I'll have a word with Russell Hardy to make sure he's aware of that. Thank you. We'll move on then to
thank you, Russell.
Thank you, Roger. The Council of Governors, and thank you, Governors, for the support you have in me as being your chair. It's a great honour. I don't take it for granted. It's been a number of years now, but we'll carry on until we have to exit stage left. The Council of Governors schedule of business for the financial year. Sarah, anything you'd like to emphasise?
No, nothing to pull out, Russell, but it's submitted for approval, please.
Any questions, colleagues, on the schedule of business? Okay, so if you're not happy to approve, please raise a digital hand. Duly approved. Thank you, Sarah. The annual review of Board of Directors standing orders. Sarah, back with you.
Thanks, Russell. So the standing orders have been reviewed by Audit Committee and Board, and we aren't proposing any changes at this stage. So it's here for ratification from the Council of Governors, please.
Thank you, Sarah. Any questions on the standing orders? Okay, if you're not happy to approve and ratify, please raise a digital hand. Duly approved and ratified. Thank you. And then we've got the annual review of committees' terms of reference. Sarah, back with you.
Thank you. So this report was previously submitted to the council in February, but unfortunately we weren't quorate, so they couldn't be approved. So submitted again with the proposed track changes, amendments as track changes for the council to approve and ratify. So it's of all of the committees under the Council of Governors. Thank you.
Thank you. very much. So as Sarah's indicated, it was discussed last time, but we weren't quite. Any questions or perspectives on the tracked terms of reference? If you're not happy to approve, could you please raise a digital hand? Thank you, Julie approved, and Sarah, thank you for your diligence in keeping an eye on all of that. Any other business, colleagues? So we'll move on then to questions from governors before I go to questions from members of the public. Questions from which have been given. Sarah, are there any questions that have been pre-notified?
No, we haven't received any, Russell.
Okay. Any other new questions from governors? Roger?
Yes, BBC are in their news channels at the moment reporting increases in whooping cough and unfortunately 5 deaths. And I'm wondering, is this a problem at Swift? Are we seeing whooping cough as a problem?
Glenn?
Yeah, so it's okay, Fiona. I see your hand going up there. Yes, it is a problem. It's been identified nationally in that there are increasing cases of whooping cough. And just to give you some numbers on that, in 2023, there were 800 cases nationally. Yet in January and February this year, there were double that number, so 1,600 cases just in those 2 months. So it is a concern. The main issue here is trying to ensure that we vaccinate the at-risk group. So it's infants and pregnant mothers. And the main issue there for very young babies is in those first 2 months. So 2 months in from being born, you're given your first vaccine. So ensuring that pregnant mums are vaccinated to transfer that immunity over to their children when they're born. So we've been pushing hard on this locally, and just to give you an indication of the vaccination response. So in 2023 for pregnant mums, the level of vaccination uptake was 61.3%. But in April of this year, it's 85.4%. So it's good to see that those conversations that we're having, but also that public awareness is leading to a higher level of vaccination. But it's obviously a concern nationally that we're seeing increasing numbers.
Thank you, Glenn. Fiona, is there anything you wanted to add?
No, I was going to say we have seen cases both in staff and patients at Swift in recent months, but Glenn gave a much more rounded view.
Thank you. I mean, I would just like to say whooping cough is a terrible disease. You really do not want to have whooping cough, and the best way of ensuring you don't have whooping cough, or your child doesn't have whooping cough, is by getting vaccinated. So vaccination for children is incredibly important on all of these type of diseases, which we can control if we're vaccinated. So that would be my encouragement: get vaccinated. Any other questions from governors? Any questions from members of the public who've joined us today? Could you please either raise a digital hand or raise a physical hand for me? Roger? Roger Olson? Roger, if you're talking, I can't hear you.
Okay, Russell.
Yes, I can hear you now, Roger. Lovely to see you.
It's not a question, but last November, I went to my GP with a chest infection, who said go straight to A&E. I went straight to A&E. I was absolutely brilliantly received there. I was admitted to one of the wards for a week. The care was exceptional. And one thing I would like to say is that the standard of the food that you're given and the quantity of it is quite remarkable. But my whole experience was very, very good, and I'd like to thank the hospital.
Roger, that's lovely of you to say so. I know also on the call We have governor colleagues who have had to be customers of ours recently, and I think their experience has been similarly good. Like I said earlier, we don't get everything right, but we get more right than almost everywhere else. So we are very blessed to have the Warwick hospitals on our patch. Any other questions from members of the public? Okay, well, lovely to see so many of you with us. Our next meeting is, help me please, Sir, when's our next Council of Governors meeting?
It should be the 12th of September, but we're looking at rescheduling probably to the beginning of October.
Yes, that's entirely my fault, colleagues. I apologise. I'm due to go on holiday, but so we will be rescheduling that, but it will be soon afterwards. But I would say to members of the public, you're always very, very welcome to join us at our monthly board meetings, and you're very welcome to join the quarterly 4 board meetings where we bring together Swift, George Eliot, Worcestershire Acute and Wye Valley, and we do a compare and contrast type board meeting. Those members of the public who join that find it very helpful and interesting. Take care, everyone. I look forward to seeing the governor members in the confidential session. I suggest we take a 10-minute break and dial in at 3:40 for the confidential Council of Governors meeting. Thank you very much. Take care.